Dr. Jay again, who will be speaking on a challenging topic of type 1 CNV in pachychoroidopathy. Is it pachychoroid neovasculopathy or PCV?
So,
So
there are
this
this,
peripheral,
yes, sir.
especially by the Jemmy Chung's group, Singapore.
Yeah, there are a couple of papers published, sir, in that regards.
Scleral window.
Okay.
Can I ask a question? Sir, what is the difference between are all irregular flat PEDs
Can you use the
or
mic,
it
please?
is
We'll OCT angio. Predictor for this thing. Okay.
Since we have two more talks to go, I think we'll just go on to the talks and then we can take up in the panel.
Yeah. So I'll go ahead with my talk on redefining type 1 CNVM in pachychoroidopathy on multimodal imaging. Yeah.
Need to click on this.
Yeah. So as it has already been discussed, the spectrum of pachychoroid spectrum, it primarily starts with a pachychoroid pigment epitheliopathy with just few RP changes, goes on to CSR, and then very long-standing CSR changes may lead to development of a type 1 CNVM, that is pachychoroid neovasculopathy, and at the end stage it may develop a dilatation, or aneurysmal dilatation at the end, what is known as polyps. So the pachychoroid neovasculopathy was first described by Bailey Frood and Claudine Pang around 4 years back. So it was primarily a type 1 CNVM that developed due to long-standing CSR changes. Now there is no established definition for pachychoroid neovasculopathy. The studies that have been done till date, they have various inclusion criteria, including presence of a CNVM, a subfoveal choroidal thickness more than 200 microns, absence of any drusins or presence of non-extensive drusins, and other characteristic OCT changes of CSE or pachychoroid characteristic, including a choroidal vascular hyperpermeability, as Dr. Anirudh had told, and along with RPE irregularities. So, like this is a classic case of a pachychoroid neovasculopathy, in which there on clinical examination there will be presence of just few pigmentary changes on that, and when we see the OCT, there will be presence of thickened choroid with dilated choroidal vessels, and present. This is the what Dr. George was talking about, a short irregular pigment epithelial detachment, and presence of this hyperreflectivity is very important because that is highly suggestive of a CNV present over there. If this is present as a hyporeflective, then it is more goes towards a CSR kind of picture. And on autofluorescence, it shows few hypo and hyper areas, and on ICG may not be very conclusive, or it may give to a picture of a plaque kind of lesion can be seen in that area. But the most important thing for these patients is to do an OCT angiography, which may reveal a network of vessels in that area, and that defines the treatment management for this. Example, this is a 70-year-old male who came with left eye decrease of vision since 1 year. The right eye had very long-standing changes of vision of 1 meter, and left eye at 6/18. So this is the fundus photograph, in which clinically also we can see presence of track marks in the right eye, and presence of degenerative changes in the macular area in the left eye. So on autofluorescence, we can classically see these track marks that is suggestive of very long-standing chronic CSR changes, and which can even be seen on the fluorescein angiography and ICG. Now, when we did an imaging of the other eye, there was presence of mild choroidal thickness with presence of dilated choroidal vessels, a subretinal hyperreflectivity, and a shallow irregular PED. On ICG, it showed presence of a very early network, but this OCTA was very conclusive. So this is the zoomed in image of the ICD showing this is the network of vessel, and correspondingly the network could also be seen on OCT angiography. So for this patient we went ahead and after we started the patient on intravitreal ranibizumab treatment. So after 3 doses we can see that there was improvement in the subretinal hyperreflectivity, with vision acuity also started improving, and there was reduction in the length of the DLS. And 12 months later, after 6 IVR, the vision acuity improved to 6/9. There were improvement in the network also. There was the fine branching vascular network, it reduced, but this dead tree kind of appearance persisted. That we even seen in wet AMD patients. But however, later, around 18 months later, again there was a recurrence, and we can see this fine vascular network has started developing again. So very long-standing changes of type 1 CNVM may lead to an aneurysmal terminal dilatation that is classically known as polyp. So these polyps can be located either in the subfoveal location, or in the juxtafoveal, extrafoveal location, or in the peripapillary area, that is very commonly seen in a peripapillary pachychoroid syndrome, or even in the peripheral location. So on OCT, these polyps will classically appear as a sharp peaked PED, or it will be like a thumb-like PED associated with the shallow DLS or double layer sign. So this is actually the network of vessels and with a terminal dilatation of the polyps. And there can even be a notching that is seen, that is classically seen in polyps, with a central hyporeflective lumen and a hyperreflective ring. The network can be seen as this shallow irregular PED. And this is just showing the feeder vessel in a very early ICG, which fills the entire network of vessels in this area. Now this is another case of a 60-year-old male who came with a right eye reduction of vision since 1 year. His visual acuity was 6/18. So there was presence of the sharp thumb-like PED in this location. And when we did an ICG, we can see the polyp with a network of vessels. And this polyp and the network of vessels can even be seen on a corresponding OCTA. So these appeared quite similar. And this patient underwent a photodynamic therapy with an intravitreal ranibizumab. And after 1 month of dose, we can see that the PED height reduced significantly. There was still presence of a subretinal fluid, but that is commonly seen after patients who undergo PDT. So that is more of an inflammatory fluid that comes after a photodynamic therapy. So this is the pre and post OCT angio, where you can see that this polyp and the network had completely resolved after doing the photodynamic therapy. And this is another case of a 75-year-old male who had right eye reduction of vision since 3 months. His visual acuity was 6/18 in that eye. Now both eyes showed presence of just RP irregularities and changes. So when we did an OCT, we can see there was a dense subretinal hyperreflectivity in that area with this shallow pigment epithelial detachment and an underlying dilated choroidal vessels. Now ICG showed presence of very faint vascular network, which was not very much visible in that. And fluorescein angiography showed an occult CNVM kind of a picture with a late leakage. So this was classically a pachychoroid neovasculopathy in that eye, and the other eye showed presence of polypoidal lesions because it had got very long-standing changes. So this confirms the spectrum, that is the patient had a PCN in one eye and a PCV in the other eye. So is that a rule? As someone had asked, whether do the patients need to undergo through all of these stages one by one? So it may not be the case. So I'll just prove that with one of my last cases. So this was a 46-year-old male who presented with blurriness of vision in 2016 since 2 years. He had a history of CSR in 2004-5, for which he had undergone a focal laser treatment. His right eye vision was 6 by 9 and left eye was 6 by 36. So these are the old laser marks that were present in both the eyes. And this is the right eye. On autofluorescence, we can see these chronic track marks can be seen, suggestive of chronic CSR changes. And presence of these intraretinal cystoid changes is also highly suggestive of a chronic CSR kind of a picture in this eye. And when we see the left eye also, we can see beautifully see these track marks on fundus autofluorescence. And and there was presence of thickened choroid along with that. And these track marks can also be seen on fluorescein angiography. So 10 months later, the patient came with a further reduction in the vision, and now his visual acuity dropped to 6 by 60. So this is the previous and this is current. So right now the patient then developed a presence of a serious macular detachment in the macular area and also just temporal to that. So these were the track marks previously, and this is at the current visit. And we can see this roundish area of hyperautofluorescence. So that is suggestive of a new disease activity that developed in this eye after around 10 months. And on OCT, when we compare, previously there was just presence of these RP irregularity changes, but now there was appearance of the serious macular detachment that came about. So when we did an angiography for this patient, there appeared to be a polyp in this area that was not there previously. So this patient had a chronic CSR initially, and after 10 months of duration, that chronic CSR it directly progressed to development of PCV. So this was the previous ICG angiography, and this is the current ICG that showed presence of this polyp that was not present previously. So this case demonstrates that it may not, that the disease may not be able to go through all the changes. So it can directly go to a PCV formation also. So just to conclude, pachychoroid neovasculopathy and PCV, they form a part of the pachychoroid disease spectrum, and multimodal imaging is the key for diagnosis and management of these patients. For an ICG is very important in these patients to identify the polyp, because it may play a very important role in managing these patients, including whether we need to do a photodynamic therapy, or for an extrafoveal polyp, even a thermal laser would suffice. And as Dr. George sir said, that OCT angio is very, very important, because a lot of patients with chronic CSR, when we do an OCT angio, we see an underlying network. So that would be the reason why these patients may be having a recurrent attacks of CSR, or they may not be responding to either the eplerenone treatment or a conservative management. Thank you.
Thank you, Jay. And with this, we'll come to the last talk of the IC.